Okay, hello everyone, and you're coming into class today. I'm glad to see all of you on time. I was a teacher for about a decade, and people weren't on time. I used to lock them out of the classroom. So I guess I've softened up a little bit. But no, just all joking aside, really glad to have everybody joining us today and just excited about this class. This is the third of four that we're having in conjunction with our Knowledge is Empowerment patient-led public policy education and action program. So today we're going to talk about accumulators mostly, but there's also kind of a subcategory called maximizers. And I would like to introduce who is here in class today. So as mentioned, my name is Tiffany Westrich-Robertson. I'm the CEO of AiArthritis, original founder, and I'm also a person living with axial spondyloarthritis. And I am joined by one of our dedicated volunteers, Deb, who's a discussion leader, and then our class speaker today, Corey. I'm going to let them each introduce themselves. So Deb, why don't you go ahead and say hello, a little bit about yourself?
Hi, everybody. My name is Deb Constien. I'm in the Madison, Wisconsin area, and I am a longtime volunteer of AiArthritis, going on 10 years or so. And advocacy is seriously a passion of mine. I have RA. I was diagnosed at 13, so I've had this disease for 40 years, and it has definitely shaped who I am. So looking forward to the conversation, and I will turn it over to Corey.
Thanks, Deb. Hello, everyone. Coming to you from Brooklyn, New York. My name is Corey Greenblatt. I'm the Associate Director of Policy and Advocacy with the Global Healthy Living Foundation. We are a nonprofit organization that works with patients across the country. I've had the opportunity to work with Deb a couple times, actually. We provide advocacy opportunities to patients to meet with legislators and share their stories and their experiences. We provide research opportunities for patients to participate in patient-reported outcomes research through our applications. And we have online support communities on our website and social media profiles, as well as a host of educational resources available at our website, such as CreakyJoints and ghlf.org, which, if you're interested in any type of information related to chronic pain or autoimmune disease or any type of treatments, I highly recommend you take a look at. Very excited today to be here to talk about copay accumulators and maximizers. So I'll turn it back to Tiffany, and we can let me know when to get started.
All righty. So yes, and thank you for that introduction, Corey. We are longtime fans and collaborators with Global Healthy Living Foundation / CreakyJoints, and just really excited to have you on here. And that is just another testament to this awesome program, because we have what we call recommended reading. And that's actually how I reached out to Corey, because they have an amazing tool, a recommended reading, a recommended use tool that we wanted to show as part of this program. So just really excited, and thank you again for joining us. All right. So these just want to thank our sponsors for making this happen, and a little bit about the participation. So as you will see, we do have a glossary, and I'm going to I have another screen here. I'm going to move this over here. It looks like this. So it's a work in progress, which means we're asking our class to help us make sure that we fill it in. This is a patient-developed glossary. We have the QR code right there, and it will help you with some of the definitions or words that we may be talking about today. And we also encourage you in the chat, if you hear a word and you're like, not sure, or maybe somebody else might find this confusing, go ahead and type it in the chat or send it to Michael at michael@aiarthritis.org afterward, and we will make sure it's on the glossary. So you don't have to like search and see if it's already there, just any of your recommendations, because if it is already on there, then hey, we're doing a good job, right? So definitely use that chat feature today. We would love this to be an interactive class. This is not your typical webinar, so there's going to be a lot of conversation, not a lot of lesson sharing or lecture sharing. I was a college teacher for about a decade and always known for interactive courses, so we're sort of modeling again around that as well. We encourage you also to just remember that just because this class today ends, it doesn't mean that the program ends. We have more classes. If you missed some of the past ones, we have recordings of them. We have a whole video library of patients talking about this in their own language, and a way of showing you how you could share your stories about this and other topics that are important to your healthcare. We have field trips, because what class is, I mean, that's fun, right? So if you are signed up as an official class attendee, you will get links to behind the scenes footage from when we go to conferences or other meetings that are related to the topics we cover. And then there's elevated experiences. And elevated experiences, well, it's kind of in the name. That means that you're really invested in this and you would like to do some things behind the scenes with AiArthritis where we could mentor you. You could speak to legislators, all kinds of elevated experience type things, including our new AI Advocates, which was our grassroots program in coordination with this, where you can be an advocate and help us throughout all of the states or anywhere you are in the world in representing our organization. Note that there is closed caption available. All right, we are off and running. So this is the agenda today, the syllabus, if you will. And we're going to start off. I'm going to talk a little bit about Accumulator. I'm going to actually turn it over to Corey because he's going to share a screen and walk through a little bit more. We'll have him include the maximizer. So you'll see he's up really quick here, and then we'll turn it into a class discussion. We again encourage you in the conversation. I see a couple people have already started commenting where you're from, and thank you for joining us. Let's move on. All right, so the first and foremost, I'm just going to touch a little bit on what an accumulator is. And it's really known also as a copay accumulator because it has to do with your copays that you have in your insurance and your health coverage. So that when we're talking about the copay, that is the amount that you typically would have to pay to gain access to your medication. And often this involves, when it comes to biologics, this copay card. I know I'm on one, and I think Deb, you are definitely, or most patients are. So the way we afford our medication is that the manufacturer gives us these copay cards, and then with those we are able to get our medication. All right, so that's what we're going to talk about a little bit today, and copay is also in that glossary. And I just put out here accumulate because I find it an interesting word. It sounds really positive. Like for me, like you get to accumulate. I'm like, that sounds good, more, right? But it's not really that great because it's accumulating for the insurance companies, which we'll talk a little bit about here. So it just makes me laugh, the name in itself. And Corey will go through this a little bit more, and then we'll talk in our discussion. But essentially, the insurance companies are able to sort of double dip into their profits because they actually aren't counting those copay assistance program funds that towards that out-of-pocket maximum or deductible. So essentially you go through and you have, all right, I'm going to use this copay card January, February, March. And usually what happens is then you also see your out-of-pocket costs go down. So like for me, I think it's like $2,000 deductible. And then after I get my biologics a couple of months, that out of pocket, if my biologic was $1,000 out of pocket, the coupon covers it, but it also takes off from my out of pocket. So my deductible goes to $1,000. Then the next month too, then all of a sudden my insurance kicks in. In the case of an accumulator, that doesn't happen. So we'll get into that a little bit as well. And then I just mentioned the deductible. So that is the amount you have to reach before your insurance is going to kick in. It is also in the glossary that I showed you. And last but not least, I kind of just mention this, but it's really about, oh my goodness, my insurance is supposed to kick in. You expect that. That's kind of the way it's always been. And then all of a sudden you get the surprise mid-year where, oh my gosh, I haven't met my deductible. My copay card has run out from the manufacturer. Now what do I do? So if you have this accumulator, it isn't being subtracted, and that obviously becomes an issue. And we're going to hear a sample of what we have from our library, which looks like this. So this is on YouTube, and we do have a full-on library of all the topics that we cover. These are all patients using their own words on how to explain these topics. And let's go ahead and listen to Lindsay explain a little bit about copay accumulators. Then we're going to turn it over to Corey.
Accumulator programs are programs used by the insurance company to make as much money as they can. Because our drugs are so expensive, many of us use copay assistance programs from the pharmaceutical companies to help pay for them. Copay accumulator programs prevent this help from being counted toward your deductible and your out-of-pocket maximum, the amount that you pay toward your healthcare in a year. Think about going to the grocery store and you have $1 off coupon for the pizza. You pay for a frozen pizza, you use $1 off coupon. The manufacturer pays that $1 to the grocery store. But then when you get ready to leave, you have to pay $1 to get out. This is exactly what the accumulator program is doing. Accumulator programs end with higher overall patient costs and can seriously impact your health.
All right. So now now that you have a little bit of an introduction to this topic, we're going to turn it over to our class speaker, Corey, and he's going to do a little screen sharing. He's going to look through a lot of what they have on their website, amazing tools that they have, and just get us a little bit more information from an expert. And we do encourage all of you, ask questions in the chat, and we'll keep an eye on those and turn them over to Corey when he's done. All right. So Corey, you can go ahead and take it away.
Great. Thank you so much, Tiffany. I won't share my screen just yet. I have a couple things to get into. But I loved the anecdote that patient just used to describe what an accumulator adjuster is. These are, as you mentioned, accumulator adjusters, maximizers. These are words that mean absolutely nothing when put together to the average person. And so it's very important, especially when you do the work that we do, when you do the work that Deb does, when you're meeting with legislators, to really break these down into ways that people can understand in their everyday lives. The way that I like to talk about accumulator adjusters, the example I like to give really quickly is, imagine you go to a drive-through, you feel like being really generous and paying for the person behind you. The place that you went takes your money, thanks you, sends you on your way. Person behind you goes up to the counter and the vendor says, hey, even though the person in front of you already paid for your meal, you didn't pay for it. So because you didn't pay for it out of your own pocket, we're going to charge you the exact same amount. This is essentially how an accumulator adjuster works. It allows the insurance company to legally collect money twice. Similarly, and I say that because it's important to understand the difference between accumulators and maximizers. Maximizers are a newer thing. While accumulators, we've been dealing with them since 2018, 2019, really started becoming very common in 2021, which I'll get into in a second. Maximizers are relatively new. Maximizers have been kind of the response from insurance companies who have said, okay, patient groups are starting to push back against accumulators. What's the next thing we can do? So they came up with maximizers. Maximizers are a way for PBMs to recalculate what your annual deductible and out-of-pocket maximums are. They say, okay, you have this assistance program. We understand you have this assistance program. Let's say you get $6,000 in assistance and your original deductible was $6,000. Your new deductible is $12,000. So once your assistance program has run out, you still owe $6,000. In, again, kind of breaking it down to an easier way to think about it, imagine you go to college, you're told the tuition is $30,000. You get a scholarship for $10,000 from a random organization or third party. And then the school says, okay, we'll take that $10,000, but now your scholarship is $40,000, or now your tuition is $40,000. These are the kinds of things that are legal because they haven't been made illegal yet. And they're the type of things that insurance companies do to push more of the cost onto patients and get patients to try and comply with the preferred formularies that insurance companies have. Now, what can we do about this? What have we done about this? Because as I said, we've been dealing with these for the last couple of years. Patients haven't just been sitting on our hands doing nothing for the last couple of years. So this is where I get a little bit wonky and a little bit policy heavy. So if there are any questions, please reach out. Happy to get to those a little later. But let's start with the advocacy efforts. So in the last couple of years, there's been a big push from advocates like Deb, like our organization, like AiArthritis, to pass legislation at the state level, which simply is a one-page law that says any payment made on behalf of or by a patient counts toward their deductibles and out-of-pocket maximums. Very simply, it essentially negates the effect of an accumulator adjuster, meaning that all copay assistance that a patient uses will count toward these thresholds. This is what has kind of led insurance companies to start to use maximizers more, is because this legislation doesn't have anything to do with maximizers at the moment. We are starting to push laws and language that would start to include maximizers as a response to this, but we've already had about, I think we're at 18 states now, including Washington, D.C., that have passed legislation to regulate copay accumulator adjusters. This also led to a very recent court ruling, which has a big impact on accumulator adjusters. This year, in 2023, the organizations led by the HIV and Hepatitis C Policy Institute, along with a few others, sued the Department of Healthcare and Human Services regarding a ruling that they release every year called the Notice of Benefit and Payment Parameters. Now, this is where I get very wonky, heavy, and policy heavy, so I apologize ahead of time. But the Notice of Benefit and Payment Parameters, or the NBPP as it's called, is an annual document that the Healthcare and Human Services Department releases that essentially sets the guidelines for any type of federally regulated health plan, or most health plans in general tend to follow these guidelines. So in 2020, they had initially released a ruling that stated, for the first time, any type of regulation regarding an accumulator adjustment program. They had a very loose definition of it, but what it essentially stated was that any drug that did not have a generic equivalent could not be subject to an accumulator adjuster program, which as patient groups, we were okay with, because we know that a generic equivalent means that it is equal and exchangeable 100% with the brand medication. The problem is that we deal in an area where most of our patients have biologics, and we know biologics don't have a generic equivalent. Some have a biosimilar, but biosimilars are not a generic of a biologic. They are not 100% equal and interchangeable. They might be interchangeable, but that's not the same thing. So because of this, the 2020 ruling was what we were okay with, but a year later, the federal government released a ruling that removed that last part of the law, or removed that last part of the sentence, and essentially said that accumulator adjustment programs could be used in any case whenever an insurance plan sees fit. This is what has since led to post-2021, many more patients starting to experience accumulator adjustment programs or accumulator adjusters, because the federal government all of a sudden in 2021 said it was okay for them for health plans to use this. So this year, HIV and Hepatitis Policy Institute sued HHS, basically saying that the 2021 ruling was not fair, that it was capricious, and it was a couple other legal words that I don't know the actual legal wording of. But their goal was to revert it back to the 2020 ruling. Because again, we're okay with there being a generic equivalent, but without the language, when that was removed, that's where we had issues. GHLF, along with 29 other patient groups, submitted an amicus brief which is a friend of the court briefing, to support the HIV and Hepatitis Policy Institute's goal and case. And on September 29th, we got a ruling from a federal court in DC that restored the 2020 rule. Now, this ruling applied to all commercial health plans. So anything including state or federally regulated health plans, including ERISA plans, so those plans that people get from their employers, are counted under this. And the decision has a couple of impacts. There are a couple of impacts and a couple of potential outcomes, depending on what HHS decides to do. And they have a few different options for what they can do. The first option is the government can respond to this decision. They have 60 days from September 29th to appeal the decision, which they could do. They could decide that this was an unjust decision and take it up to the next court. Additionally, the government could reenact a version of the 2021 rule through a new notice and comment rulemaking period, where they adopt a more specific definition of what cost sharing is and try and get something that's more closely related to how the court has ruled. And additionally, the government could say, okay, we accept the rule, we're going to revert back to 2020, or we're just going to release a new rule that says we're going to codify the 2020 rule as the ruling we're going to do right now. That would be the preferred rule from patients. That'd be the preferred outcome for patients, but that's not necessarily what we know is going to happen. We have to kind of wait and see. We have about 60 days to kind of wait and see in this case. And from that regard, insurance plans and PBMs are also in this wait and see mode. They're going to likely proceed as if this ruling didn't happen and that there will be an appeal. So they will continue to proceed with accumulator adjuster plans. But if 60 days from the ruling date, HHS does not appealed and has not released a new ruling, then we will likely see these plans submit new guidelines that do not have accumulator adjusters in them. Now, what does this mean from an advocacy perspective? Because unfortunately, it's not a situation where the ruling was passed and we can all go home, kick our feet up and say, hey, we did it. This is all done. We won. Insurance companies have to do what we want. Unfortunately, that's not how this works. This is a ruling. So like all kind of court rulings, not only could it be appealed, it could be changed in the future. There's nothing codifying the language into law. So there still needs to be an advocacy effort at the state and federal level to pass laws that start to actually codify this language into law and make it so that patients are protected and patient assistance programs are protected. Additionally, this rule has nothing to do with maximizers. The 2020 NBPP didn't have to deal with maximizers. So it had no language in it that dealt with maximizers. And as we said, now we're starting to push for that at the state level, but there's nothing that is in this rule that does anything about maximizers. So we still, as a state advocacy organization, we still have a goal to make sure we're doing what we can to outlaw these programs as well. Additionally, one of the more kind of side parts of this is that the ruling does nothing to enforce to force PBMs to not just reclassify what an accumulator adjustment program is at their discretion. They might be able to change the language around it, similar to how they created maximizers. They could create a different third thing that wasn't included in the 2020 NBPP, but also does kind of fit around that language. There was nothing in the court ruling that says that like the language that's being passed at the state level, that any payments made have to be counted toward these deductibles and out-of-pocket maximums, and these thresholds cannot change. So all of that means that advocacy is still needed. This was a step. This is a big step for a lot of reasons, but this is still just a step along the way. And advocates know that we have a long way to go. With that being said, organizations like GHLF are doing what we can to make sure that patients are really able to have the full set of tools in our toolboxes when we talk to legislators. So I'm going to share my screen now and get into a little bit about a research project that our organization did to provide patients with one of these tools and one of these resources. So as patient advocacy organizations, we understand that the best way to connect with legislators is to combine a patient story and personal experience with data to back it up. Because more often than not, when we bring patients into these meetings, we're confronted with legislative staff or legislators who have been inundated with data and statistics from pharmaceutical companies and pharmacy benefit managers and insurance companies who are able to bring concrete statistical evidence. And for the longest time, patients haven't been able to get access to that type of data because insurance companies don't share. They don't give us their info. So we had to kind of create our own based on publicly available data. And that's something that our organization decided to take on this year. And it's something that we did specific with regards to copay assistance and copay accumulator adjuster programs. So one of the things, and so this website is first off, a explainer on everything we've talked about regarding assistance programs and accumulator adjusters. This is part of our website. If you go to ghlf.org/copay assistance protection, you can see this. This is one of the many pages we put together, but this is one of the more thorough. And it goes through all the things related to copay assistance. So what is a copay? What is a deductible? What is an out-of-pocket maximum? What is an accumulator adjuster? What is a maximizer? And it shows a map of all the states in blue that have passed legislation and the states in orange that have not. And the reason we want to do this comparison is because every time we would walk into legislative offices, we would talk to legislators and we'd say, here's our patient story. What are you hearing from insurance companies? What are they telling you that we can start to say is wrong? And the thing that we would always hear was that insurance companies would respond to them that any effort to pass legislation like a copay accumulator adjuster ban, like a step therapy ban, any type of regulation that reduces their ability to make changes to their formulary will increase premiums across the board for all patients in the state. And we always kind of thought that seemed wrong, that there had to be some type of data that proved that that wasn't true. And there was proven. We looked at premium data from the last 10 years across every state in the country. And we tracked how much premiums increased year to year across these groups and across states. We looked at all different types of plans. This is just everything aggregated, but we looked at bronze plans, silver plans, gold plans, all different tiers across individual and small market plans and across every state. But everything booked together, that's what it looks like. And yes, while there might be a $25, $50 difference there in the middle for a few years, right now in 2023, those lines are basically touching. It'll show you that as more states come into the mix and more states pass legislation, and we're seeing this start to become balanced, the numbers show that passing this type of legislation does not increase premiums across the state by a significant margin. So you might say, okay, that's everything. We're a big country. We're a lot of different people, a lot of different demographics. Well, okay, let's go down to our little map down here. So this map which will be lit up in a bit, gives us the ability to look at every state put together 100%. Now, this is a confusing mess. Yeah, I'm not gonna lie. This is shows everything. Now, yeah, you can see Vermont is at the top here and doesn't have a law, and New York has one, and it's right there. But let's try to break this down a little bit. Let's try to go for states that are similar for each other, so we can kind of show what maybe some common states look like, and we can kind of compare what two states that have a law and don't have a law look like. So let's have the passed and non-passed as a parameter, and let's start with, how about we do Oregon and Washington, two states in the Pacific Northwest that you'd say are probably pretty similar demographics. And look at that. Washington has lower premium increases than not only the national average, but than Oregon. Oregon is also lower than the national average, but it's still higher than Washington. So you can say, okay, that's just two states. What about a couple more? So, okay, let's see. How about we do Colorado and Utah? Those are, again, two rocky states, two Rocky Mountain regions. You'd say pretty similar demographics. And look at that. Utah has a higher percentage of the premium increase than not only the national average, but Colorado is way down there, all the way lower than the national average. So again, you want to say, okay, well, that's two. What about that? That's all the West Coast. That's everything west of the Mississippi. What about something on the East Coast? Okay, so let's try Georgia and Florida. And what do you know? Once again, you got Georgia way down here and Florida right above the national average. So I'm not saying that this is everything is going to look like this. Obviously, we saw when we had everything together, New York was among the highest out of everyone. If we do New York with every state next to it other than Vermont, as we saw, it would be higher than most of them. But it does show something very important, which is that the things that we are being told by insurance companies and the things that legislators are being told by insurance companies are oftentimes not the truth. And we need to come into this as patients who now have data to be able to say, okay, we're a patient group in Utah that's looking to pass this legislation. Are all of our neighbors, Colorado, Arizona, New Mexico, they all have this legislation passed. All of them have lower premium increases than us. They all have shown, if you look at the map, now when they passed the legislation, premiums did not go up on the map. They stayed pretty still. So the way we want as an organization to utilize this data is to be able to show legislators in specific states, compare them to the states that demographically are right next to them, have very similar issues, and show that one of the main talking points of an insurance company as to why this bill should not be passed is not true. Which means that if that's the one thing holding a legislator back, it shouldn't. And we should be able to move people along to get more people to support these laws. Now, you can play around with this in a lot of different ways. I chose silver plans because we know that about 70% of health plans sold are on the silver tier. More plans, I believe, are on the individual and the group market, but you can play around with this however you want. Most of the time, the results come out very similar. So this is all available on the resources that Tiffany provides. This will continue to be updated as more states pass legislation. I believe our plan is to update it every 6 months. And it is freely available for anyone who wants to use it. And yeah, that's it for that. I think also that's it for me. So I can throw it back to Tiffany now, and we can throw it and see if there are any questions.
All right, and yeah, it is by no way, shape, or form the end of you here, Corey. You're going to be with us here in our class discussion. I am putting the link directly to that in the chat right now, and it will also be sent to everybody who attended or registered to participate with the resource links as well. So I did have a couple questions really quick, and then I'm going to turn it over to Deb to ask any questions and actually to talk about what happens if you suddenly have an accumulator. So we'll get at that here in a minute. I wanted to ask you, Corey, could you explain, we saw the map and there were some states who had legislation that were in blue, and then there were some that did not in orange. So for the people participating who might want to try to help get things passed, should only the people in the orange states be doing anything, or are there things that patients in the blue states could also be doing?
That's a great question. I'm really glad you asked that. So there is definitely things that people in the blue states can do. I mentioned that there is also a federal effort. This is the next most important thing. If your state has passed legislation, is to get your federal legislators to support the Help Copays Act, HELP Copays Act. This is essentially the federal version of these state bills that we are passing. It is an attempt to make sure that any plan that is under the ERISA plans, so any plan you get from your employer, is covered by these regulations and is protected under these same laws that the state plans are. It is as important as getting state plans passed. So if you're in the blue states, not politically speaking blue as in passed this legislation blue, please reach out to your legislators, your federal legislators, see if they are currently sponsoring this Help Copays Act. And if they are not, that's your task, is to make sure that they sponsor this legislation.
Okay, thank you for that tremendously. All right, I'm going to turn it over to Deb. First of all, any questions or clarifying questions? And by the way, Corey, I just loved that tool. I saw it advertised. I subscribed to everything Global Healthy Living Foundation, so I got the notification when it came out, and that's when I said, oh, I know who we need to have on the accumulator for our class speaker. I just really wanted to give props because I just think that, first of all, it's true. Data, so important. Without it, then stories matter, but stories with data, like, it's really hard to challenge that. So I just wanted to give you props. And all right, so we do have a couple questions coming in. I'm going to let Deb start, and then we're going to circle back to some questions.
So I've actually been part of the coalition in Wisconsin, and they've got a all copays coalition going, and I've been part of that for a couple of years. And it's growing as time goes. So it's been, an education. I've always been talking about the accumulators as how it would affect me if I was if I actually had an accumulator. Well, guess what? October 2nd, I get a letter from my insurance company, and it's interesting because I have Anthem, and this is for Optum RX. And it says important copay card information. And I actually almost tossed it because I was thinking I'm waiting for a medication approval. So that's what I kind of thought this was. And then it says, Dear Deborah Constien, many people look for ways to save on high-cost brand name medications. One way is to use copay cards from drug manufacturers. Copay cards can lower your prescription drug out-of-pocket costs, but there may be limits on how much you can save each year. Starting January 1st, 2024, if you use a copay card to pay for your prescriptions, the amount covered by the copay card will not count towards your deductible or your out-of-pocket maximum. Only your out-of-pocket costs will be applied to your deductible. So, and that gives an example. And the example it uses is the copay card covers $350 of your medication that costs $400. Your member cost share of $50 is the only amount that's going to count towards your deductible. And Tiffany, you had a comment about that. Again, how go
Yeah,
ahead.
I mean, not that 350, that's a lot of money. But I do think it also would be a lot more eye-catching, which they don't want it to be. They want you to just scale over this, right? If it had the real cost of like our biologics, right? Like if it said 5,000 or 10,000 or whatever it is, and then you start, it grabs your attention a little bit more. So I think that for me, when you first shared that with me, as a patient, what I found the most deceitful is how they're framing it, that this is a good thing.
Right. And like it's so nonchalant, and they want it to just scoot on through. And it says questions. We're here to help. And it says call the number on your member ID card. Thanks for letting us serve you and help you make the best use of pharmacy benefits.
We should all call right now. No, I'm kidding. Let's not do that. Like live on the web, on the class. Let's all call Deb's insurance company.
Joke. I mean, seriously. And like, I sent a screenshot to you right away, and I'm like, huh, how timely. And it was October 2nd that was dated. So it probably got to me by October 4th, 5th. And I mean, here we are on the 13th, and man, oh man, it's just very eye-opening. And you know, Corey, you made mention that with everything that's been actually going on, I have to kind of wait to see what happens through some of this federal stuff that they're, you know, negotiating right now, correct?
Yes, there's a good chance that if no appeal is made, or if HHS decides to codify the 2020 rule, that your insurance company will have to reissue this letter or their plan, because you will not be allowed to be subject to an accumulator adjuster.
Right. And fingers crossed. Again, we've been working on legislation here in Wisconsin for a while now. And for state legislation, what's happening is they're combining it with the PBM legislation. So they're thinking they can actually get better traction by combining it right now. So yeah, I've already been to the Hill twice this year and been talking to legislators, and my representative has signed on as a co-sponsor, but both of my senators haven't. And it's interesting. And Tammy Baldwin is saying that she's waiting for better language to come out. And Ron Johnson doesn't sign on to anything, like ever. So that's no surprise. But I was actually surprised that Tammy Baldwin, who's a Democrat, she's still waiting for better language. And I'm like, what language is bothering you? And of course, I'm not given an answer. So it's interesting. And I know we've been working on this for at least 2 years now. And we're further along in Wisconsin than we have been, but just the education around this and some of the examples. I mean, I've heard some of the best examples I've heard. Again, what Lindsay used as far as like a coupon, and Corey, you used like 3 different examples, and some of the best examples that I've heard, because there's so much confusion, and people are just getting lost in the jargon, and it's tough to understand. It's not easy.
Yeah, I completely agree. And one thing I didn't mention, which I started to mention and then admittedly kind of got sidetracked, but
That happens all the time.
related to biosimilars and biologics, because this is a question that we've gotten from our organization a couple times. Biologics, because biosimilars are not generics, should be safe by this ruling, that they should still be considered that they do not have a generic equivalent. So in that sense, they should not be subject to an accumulator adjuster. Biosimilars are still not necessarily the cheapest things in the world. So unfortunately, they likely will be subject to accumulator adjusters if patients are forced to deal with them. So that was something I meant to answer before. But again, as I said, kind of lost my train of thought and swerved back to what I had been talking about prior to that. So I did want to make sure I mentioned that.
Yeah, and I actually have on the next one of the next slides that I'm going to share as we wrap up some of this is I mentioned that as well. Deb, real quick before we have a question here from Deanne that I definitely want to share here. I just was curious. I mean, you have sat, as you said, on this state level coalition for a couple of years. You've gone to the Hill. You've talked about this. You're not the average patient. You got a letter and you almost threw it out. Like,
Right.
it almost
Assuming.
went by you. So
Right.
I feel like a big takeaway and something that we really have to make sure that we're letting patients know this time of the year is when you're going to start to see these letters coming as well. And really, if you're getting a letter from your health insurance provider, please, if you see the word accumulator, that do not throw that away.
And actually, this doesn't use the word accumulator.
Oh, it didn't. I thought when you
Not
read
at
it,
all.
oh, it just said copay.
Yeah. So important, the upper corner, sorry, right over here. Important copay card
Okay.
information.
Good. I'm glad that I said that then.
Yeah, and it talks about copay cards. And again, I'm glad I'm not backwards, but even down here with the example of how it works, they make it look just easy peasy and not a big deal. This is not a big deal. That's how they do this.
They leave the whole part off that what this means is when we hit mid-year, that $50 is going to turn into the full 450 or whatever the original was. Okay, I want to throw out, we have two questions here. The first one, my insurance hasn't done this yet. Are they allowed to do it at any time?
So it's a great question. The times that they would likely do it are similar to with Deb's situation, near around when you would re-up your plan. They would not likely do this in the middle of a plan year. So some health plans start January 1st, some start December 1st, some start November. Around this time of year is when health plans start to have their annual restart. So health plans will likely 30, 60, 90 days, depending on state statute, will send a letter that details what changes they're making to your health plan, or if they're not making any changes, what your standard health plan looks like. So they will send you some type of notice on this.
All right, thanks, Corey. And then the other question from Sarah, with these circumstances, can an independent medical review assist with this?
I do not believe so.
I wasn't sure.
Yeah, I do not believe so, because it's not a determination decision. It is a policy decision based on how the insurance company has set up their formulary. And as we kind of touched on a little bit, they utilize these assistance or accumulator programs to try and steer people toward the medication that they want you to take. And we know that an insurance company is not the doctor who prescribed that medication, so they should not be making prescribing decisions for you. And oftentimes the one that they're pushing you toward isn't the one that's the works best for you. So if you are one of the lucky people that it is, you probably will never have to deal with an accumulator adjuster, which is great news. And I am so happy that's the case. But we know that patients with chronic conditions and autoimmune diseases are like snowflakes, and many of them have very different treatment regimens and different treatment needs. And so we can't use a one-size-fits-all model onto this, which is what insurance companies are trying to push onto people. And that's why they utilize this. So I see your question. If it deems it medically necessary, can an IMR assist to back that up? Maybe. I don't know enough of an answer on that, though, to give you a solid yes or no. But maybe.
Yeah, that's a good question. I'm going to record that and look more into it as well. That's a good question, Sarah. All right, so I'm going to go ahead and share my screen again, and we're going to keep your questions coming if you'd like, if you have more. I'm going to move forward in the interest of time, just to finish with the class. And let me hit my share screen. I've got share sound. All righty. So how does this impact rheumatology patients? Why should I care? I think we covered a lot of these already. So that's a good class right there when you get to this point in its review. So in the chat, please, let us know, do you rely on these programs? I saw Lisa, thank you for your comment. What about this issue concerns you most? Why do you care? Lisa had said, well, I care because I couldn't afford anything if this would happen to me. So, what happens? I mean, I haven't had this happen to me yet, knock, knock, but doesn't mean that I'm not going to get my letter in the mail here any week now. Oh, little spelling error there. Sorry about that. There, as you already mentioned, Corey, a biosimilar is not a generic. And I think that's important for us to think about as well. So I actually wrote when I was doing this, okay, so biosimilars are still expensive. So, I mean, if it's like, okay, we'll switch to a biosimilar, so I don't understand what that's gonna even do, because it's not like they are generic priced. What happens? And this is something you also touched on, Corey, that I think is important. We are all individual. Just because you have a disease that says you have rheumatoid arthritis or you have psoriatic arthritis, we are all treated the same. And there's nothing worse than disrupting continuity of care. Nothing worse. It takes a long time to find the right treatment. If you're pulled off, especially for price issues and it non-medically switched, then you are just have a much larger possibility of never achieving remission and developing comorbidities. And it's just, this all ties in to disruption of continuity of care. These programs, the copay assistant plans, are there to help us make sure that none of this happens to us. So disrupting that in itself, it's just something that we need to understand, being rheumatology patients. And I don't think it's in this video clip that I'm going to play of Michael, and Michael's the one helping us lead the chat. I love Michael's videos. They always make me laugh. But in a different one, he was like, who cares who pays the out of pocket? Like, if my aunt gives me X amount of money, or the card, who cares? Like, you're getting your money, just leave us alone. So I'm going to play another video from our library that shows why Michael thinks that patients should care.
So you're probably asking, what does a copay accumulator have to do with me? And long and short is, it makes you pay more money somehow. Either you're paying more money up front, or you'll be paying more money in the back end. So how does that happen? How it happens is that the drug companies will give you a coupon for your medicine, a coupon or gift card or something. It's not a gift. I mean, you have to spend it on their stuff, but they're giving you something to hold and to pay for your medication, to help you out, so it's not coming out of your pocket directly. It's not as much as coming out of your pocket. You're gonna have to pay something. But they're trying to limit your exposure. So how this affects you, accumulators affect you, is the insurance company says we need to save as much money as possible. And we're going to do it by not allowing any money paid by the drug companies in the form of a rebate or a copay card. We're not going to let any of that be factored into a deductible, even though it was given to the patient and the patient pays with it. So they are very specific about it.
So another, just reiterating what we've been saying here. So the next phase, and something that Corey was talking about, the patient stories matter. So making sure that we're talking to legislators, talking to the people in our states that are the decision makers. We already, I'm not going to read over these specifically. You can all see this is something we've already said why stories are important. But I do want to, we will share it with you in the chat here and afterwards. If this is something that you are very interested in here on our website, and there's a lot of organizations that have similar setups. So if you go to our website under aiarthritis.org/policy voices for any issue with it you feel you're having with your healthcare or with access to treatments, you can share your story here. But for very specific issues like the support, the Copays Act, so this is that federal level, this is the nationwide. So any of you can fill these out. You literally just type in your name, your last name, your address, and then you start to go next. You'll plug in your zip code. It pops up with your legislators with a letter all ready for you. You can edit it to add in your story, and then you hit send, and boom, it actually just goes right out to them. So these types of things are really important and fairly easy to do. And saying that we have it all, the template all there, so you can feel very confident that the points are right, but are good points to have, but you can also feel free to edit it, as I said. So that is an opportunity that I think if you have not already done that, definitely do something like that. And the other part of this program and why we wanted to do this with really peer-to-peer education, getting experts to speak and really help us understand in layperson terms about these, is we are hoping that by learning about these, we all talk to each other. We know each other in social media or in community groups. So I'm hoping by listening and hearing these examples and going to our video library and hearing more stories and more examples from your fellow peers, that you can start to recognize, oh my gosh, somebody just mentioned this. They just got a letter in the mail and it was something about their copay card. Oh my gosh, that's an accumulator. And you can start helping us help them. So we really are hoping that this whole program will help you be able to help others by the knowledge that you're gaining through this. And if you want to create a video, you don't have to be a regular volunteer with AiArthritis. That was our first round of videos. If you want to do this, you let us know and Michael will connect with you and we will get a recording of your video and we will put it on our library. All right, quiz. I mean, what class without a quiz, right? So here you go, quiz yourself. I feel I could briefly say what an accumulator issue is. Yes or no? I feel I can provide at least one example why an insurance company applying an accumulator to my plan may not be good for me. And 3, if I heard someone else sharing this story about a letter or maybe suddenly mid-year, they have to pay full price, that I'd be able to say, hey, I think that's an accumulator. And in those cases, like I had just mentioned, please send them our way and we will give them more direction on how to navigate that situation. So you don't have to share with us in the chat if you don't want to. This is more of a self-quiz, grade yourself. But if you even answered one of these as a yes, then I'd say that we've done a good job here. Just an FYI, again, the action plan, in addition to sharing your stories, you can get more involved in this program by signing up. Many of you probably already have signed up to be part of the class. And that means that you get notifications to join things like this. You get notifications to get behind the scenes on our field trips. We just had our first field trip for this, and it was in Washington, D.C. So there's a shout out to Anika there on the top right, and she's on the left. She's our new International Advocacy and Policy Director, and that's me on the right. And we are with Leah from the Center for Medicare and Medicaid Services. And then I just love the little picture of Anna. She's with the Arthritis Foundation, and it just shows you that, just like Corey being here today, we all are working together for the same fight, the same cause. So it's just nice to know that you either get to meet these people when we go on our field trips. And there we go. That is a wrap. I just want to thank everybody on behalf of AiArthritis. Corey, thank you so much for coming. And if there's any other resources that you would like us to share, please let us know, and we will make sure in the follow-up that we do that. And we always want to give a shout out to our volunteer patient committee who has helped create this program, helped design everything, our volunteers, got them all listed. Deb, thank you for joining and being part of this. And again, if you're signed up for the program, you also want to be more, or you want to be more involved, please just let Michael know. This is his email, and he is here to get everything going for you. So that is it. Class bell has rung, and we are going to be signing out. But thank you all, and tune in when we do continued classes here in the near future. Goodbye,
Have a good day,
all.
everyone. Bye.
Bye, everybody.